we are. I'm going to jump into this vascular lab. Sorry about that. Took me a second here. And so standard disclosures. I'm jumping into vascular lab first, just because I know we all have RPVIs. That's part of the board requirement. All programs nowadays have a vascular lab section on there. Critically important in what we do. You know, we have to understand the vascular lab. We have to make that place our friend. We have to be very good at it because that dictates in what we do. And so I'm just going to hit some basic topics, and they do, and it's a couple of questions. They do cover these topics on the boards again, and it may not be a direct hit. It may be one of those, yeah, they may give you a vascular lab finding with some sort of disease process, and then you've got to figure out what's the step in treatment, or what are you going to do? So it may require a little bit of analysis there. So we will go over some basic principles through the vascular lab. We'll look at PAD. They do hit transcranial Doppler to this day. A little bit about carotids and mesenterics and renal disease. And finally, we will hit venous disease, which I think is important for us to know as well, because they may give something like a reflux exam, and you may have to analyze and then decide what's the next best treatment or exam, or what are you going to do next for it. So we'll go through these just a little bit. And I know you guys have the background. It's just a refresher, so that you guys will be ready for the exam. So let's go over it. The basic principle, the basic idea behind this is stenosis causes a pressure waveform to dampen, and the highest frequency components are affected the first, right? So thus, whenever you look at something, especially, you know, we analyze carotids all day long, right? The first thing I look at is peak systolic. It's more sensitive, the map or the end diastolic. The flow through the channel results in a pressure drop by kinetic loss, and these increase with flow, right? So, yeah, whenever I'm looking at it, especially I'm at an institution where I get a lot of outside studies, and I look at it and they always give me some funky percentage, you know, 40 to 69% stenosis. I'm like, well, what does this mean? And so I always look at that peak systolic velocity first. Granted, I don't trust half the outside studies. If it's my own lab, I know I've got control. I'll look at it. I can figure that out. But when it's outside, I always usually do confirmatory tests, like such as a CT angiogram. But it's always important to analyze more than just the numbers, whoever's reading it, that you analyze it yourself. So I like to look at that peak systolic first. Basic principles, right? Change in frequency, all this kind of stuff is kind of complicated things that I would not waste time looking at it, but just for completeness sakes, change in frequency is 2 times velocity times transmitted frequency times the cosine of the angle over c, and c is the velocity of sound through blood. And so that's one of the basic formulas that you have. And then the other one is velocity equals frequency times wavelength, right? And so those are the two basic formulas that they derive most of the duplex ultrasound information from. Duplex combines pulse spectral analysis with anatomic, right? So you've got that B mode, or the brightness mode, and color imaging. And then you've got this criteria that's been developed by Astranis to deal with the limitations of ultrasound imaging of the carotids, right? So you, in this day and age, in particular, you are not looking at, like when we do a lower extremity exam, nowadays, you may do a spot ABI down at the ankle or the toe, but an ultrasound, a duplex ultrasound, will give you a lot of anatomic information as well. And it's important to combine the two, especially if you are doing a surveillance follow-up for a stent or something like that. You've got that ultrasound information that will give you a lot of little details that'll help you prevent shutdown. So if you stay on top of it, it's critically important. So color Doppler, you've got the pixel flow, you've got power Doppler, it's blood flow based on backscatter signal. And then you've got pulse Doppler that provides you waveform for you to interpret, right? Peak systolic, end diastolic, the resistive index, all that kind of stuff. So the duplex ultrasound can give you tons of information, and you've got, some of the newer systems have a lot of these little things built in, so you could just toggle between the two, and it comes out great. So, yes, pay attention to your duplex ultrasounds. So the next, we're going to jump into a little bit about peripheral PAD, ABI, some of that testing, as some information about the ankle brachial index, segmental pressure, stress testing. So the first one is ABIs, right? And so sometimes they even, and this was an older question, they just had a simple question of how to do an ABI, right? You're going to compare the ankle pressure with the upper extremity pressure. If no PT or AT, you can use a tarsal branch, something like that. Automatic blood pressures work differently than vascular labs ABIs, right? So when we do it and I bring this up in that I get a lot of these patients who may have gone to church or some community event, and they go to these mobile labs, right? And they use these automated systems, and all of a sudden they come up with these funky numbers, and then they come to you in a panic and they say, Doc, my thing says I am 79% blocked in my carotid. I need this fixed. Well, you got to take a look at what they're doing, and you got to realize they've used some automated cuff. It's just one spot check on or on their ABIs. We're talking about ABIs. They did one. They've got an ABI of 0.4. Doc, I got to get this fixed. Yeah, they did one spot check, one cuff. It was an automated system. They have no idea what they're talking about, right? And then 9 times out of 10, they're going to come in and you actually feel a palpable pulse. And you're like, all right, this doesn't match up. Well, yeah, when you do it in your vascular lab, you've got a lot more higher end equipment. You're going to see that it works differently. And that's how you're going to come up with some of this stuff. So when you are looking at it, you are looking at the highest ankle pressure over the highest arm pressure, right? When you do a surveillance follow-up, usually you have somebody coming in at 6 months or once a year. Beyond looking at the ultrasound, I like to have just hard numbers, and hard numbers are great for the primary care as well, that you can send it back to them and say, hey, these numbers are kind of within what I see as the norm, and looks like he's holding just fine, right? So standard deviation of 0.07. Anything greater than 0.15 is a real change, right? Especially if you're doing it in the same lab. Anything that's a difference of 0.15 is something that you want to pay attention to. Peak systolic increases distally. The normal ABI 10% greater than the brachial. All right. When you look at the numbers and you're trying to interrogate what you've got, and that you guys are now experts at this, you will look at an ABI and anything greater than 0.5, unless you have somebody with multifactorial smoker diabetic, right? Usually single level, something SFA, some sort of iliac, something or another, you can nail it with one shot. Once you get below 0.5, you start to get worried. Yeah, I'm going to have to do a lot more work. And so that's where, your clinical exam and your numbers play into effect, right? I will always check for a femoral pulse. If I don't have a good femoral pulse, that's going to play into my thought process, and especially how am I going to stick that patient, right? Antegrade, retrograde, all that kind of stuff plays into your mind. Duplex scanning more sensitive than ABIs for detecting subclinical disease. Always check both arms. Even in my office, my MAs know that I will get crazy if I don't have both arm blood pressures, especially in my carotid patients, right? You may have some sort of subclavian stenosis that you don't pick up on, and you're getting all sorts of funky ABIs just because you used the wrong number, right? Let's check both arms, supine, cuffs. There was one time there was a question about the wrong size cuff. And so you got to just make sure that the cuff is the right size that you're using. The length 80% and width 40% of the circumference, okay? So just know that you be careful with that. Segmental pressures, decrease of 20 millimeters of mercury is real. ABI pressure of greater than, ankle pressure of greater than 60 millimeters mercury to heal 80 in diabetics, right? Toe pressures. Yes, toe pressures are really critically important, especially in the diabetics, right? So you need to sometimes get those toe pressures when the regular DP PT will give you some abnormally high numbers, like you're getting 1.3, 1.5. Yeah, it's because your vessels are calcified and you cannot, they become crunchy and you cannot get a good occlusion on them. So you need to use toe pressures. Exercise testing, really helpful in sometimes the younger patients, right? That you don't suspect PAD, but there may be some sort of other abnormality that you're looking for. And so exercise testing is also helpful. Supine for 20 minutes, 2 miles per hour at a 12-degree incline for 5 minutes, and then stop. It can unmask some other things, especially, popliteal entrapment or some of these other things that you may not look for. And so sometimes a younger patient who fits that description, I will order that exercise test. So be careful about that. Normal waveforms, we'll look at when you kind of go to interrogate or look at this, right? When you see changes with disease, first you look at spectral broadening, right? Things start to widen out. Then you'll look at blunting, the peak systolic and end diastolic will start to come down, increase in systolic velocity, greater than 50% or more, and then that doubles your peak systolic, right? So yeah, those are things that you want to as you look at waveforms, right? You kind of see, oh yeah, I'm seeing some broadening, some blunting, leads you to conclude that something is looking a little bit different and you need to be a little bit more suspicious, right? All right, transcranial Doppler. It's one of those that I think is just a board topic. A question pops up every year or two about these transcranial Dopplers. They are painful. It's straight memorization. We hardly use it, but I think, just for completeness and just to make sure that we cover it, you just look at it. Let's go through this. You scan through the temporal orbital foramen magnum to assess the MCA, ACA, and PCA, right? The goal is to look at collateral circulation, intracranial stenosis, and arterial spasm. It's all been changed with CTAs, right? But again, it's a little bit of something that has been used in the past, and sometimes that question